A very good evening to one and all. It's a honor to present the monthly Indian Society of Nephrology Journal Club on behalf of Manipal Hospitals, Bangalore. The topic for this month is severe hyponatremia correction, mortality, and central pontine myelinolysis. This was a recently published article in NEJM Evidence. It was published in September 26, 2023. Every time you open a textbook or a journal to read about a hyponatremia, the first thing you encounter, the first line you encounter is the most common electrolyte abnormality among hospitalized patients. Even the current journal, which we are discussing, was also started with a similar sentence. We all know that hyponatremia is common. How common it is? This was a data which was published from Netherlands, which it was a retrospective study from 2000 to 2014, where they screened around 2.3 million hospitalized patients, and they found out that at hospital admission, roughly 14% of patients had hyponatremia, that is less than 135, and 14% of 2.3 million is roughly 3.5 lakhs patients. Roughly around 3.5 lakhs patients were admitted with hyponatremia over a period of 14 years. And this study highlights how common hyponatremia is. And coming to the distribution of hyponatremias, majority of patients, according to this study, which was published in 2006, which states that majority will be admitted between 130 to 126, and roughly around 1 to 2% will be presenting with, will be getting admitted with sodium less than 116. That is with severe hyponatremia. But why hyponatremia is important? These were the earlier reports. There are evidence that hyponatremia is a presenting complaint with which patient can present. And for example, a patient with a lung cancer can be diagnosed with an hyponatremia, which later turns out to be an SAIDH, or it could be an adrenal insufficiency. And the management of hyponatremia is complicated by two neurological disorders. In the acute phase, it is characterized by cerebral edema, and during the correction phase, some patients can develop osmotic demyelination syndrome. And invariably, having an hyponatremia is associated with increased morbidity and mortality rates in hospitalized patients. So what does the guideline says regarding the correction of hyponatremias? The US guidelines which was published in 2013, which divides the patient into two categories, the high risk and normal risk. In high risk patients, the guidelines recommend to limit sodium correction, 24-hour sodium correction to 8 milliequivalents per day. And who are these high risk patients? Those who are presenting with serum sodium less than 105 and who has risk factors for osmotic demyelination syndromes like hypokalemia or hypophosphatemia, or who is an alcoholic, or who has severe malnutrition or advanced liver disease. The 2013 US guidelines recommends to restrict the 24-hour sodium correction to 8 milliequivalents per liter. And in normal risk individuals, the guideline recommends to 10 to 12 milliequivalents per liter for 24 hours. Another European guidelines, which was published in 2014, which is almost similar to the US guidelines, which states that the 24-hour sodium correction to be limited to 10 milliequivalents per liter. but what happens in clinical practice is that sodium correction rates are frequently limited by neurological complications to prevent neurological complications, and many physicians are reluctant to use 3% hypertonic saline because of the fear of overcorrecting the hyponatremia, and frequently physicians tend to apply sodium re-lowering strategies to bring back the sodium to the recommended guidelines rate. And what has been reported is that even central pontine myelinolysis has been reported even when the guidelines recommended range has been achieved. Say for example, from this 2008 study, they reported a case where a patient developed an central pontine myelinolysis within the guidelines recommended range. So to answer all these questions, the current study was put forward and to look for any association between sodium correction rate and development of osmotic demyelination syndrome, and look for any association between sodium correction rate and mortality. Though there were previous studies, all were very small quantities, were small in numbers, and this is one of, to answer this was conducted in a large number, and also to look for the sodium correction rate and its association with length of stay in hospital. To answer all these questions, the current study was conducted. Coming to the methodology of the study, it was a retrospective observational cohort study where they took patients from two big hospitals, Massachusetts and Brigham hospitals. It was a registry data registry study from 1993 to 2018. Almost 25 years of screening was done in this study. It was a retrospective observational study, and their inclusion and exclusion criteria is fairly straightforward. They took patients who are at least 18 years of age and who are getting admitted with an index sodium of 120 milliequivalents. And this 120 milliequivalents should be within 24 hours prior to the admission or within 24 hours after the admission. So by their inclusion criteria, they made sure that they're taking only severe hyponatremic patients and whom are presenting with acute hyponatremias. And they excluded patients whose index sodium is after 24 hours of admission, and they excluded patients whose blood glucose level is greater than 300 milligram per deciliter and whose blood samples was hemolyzed. And these two were excluded because they want to exclude pseudo hyponatremic patients. So by using this inclusion and exclusion criteria, they screened almost some 13,000 patients, and they excluded around 2,000 patients whose samples were hemolyzed, and around 6,000 patients whose sample was collected after 24 hours, and whose blood glucose is more than 300 milligram per deciliter. And finally, they were end up with a total sample population of about 3,274. Which is quite a huge in number. And this 3,274 patients who were admitted with hyponatremia, severe hyponatremia, those patients were received treatment for sodium correction, and they divided patients into three groups. Those patients who received a 24-hour sodium correction less than 6 milliequivalents per day, or 6 to 10 milliequivalents per day, and those patients who received more than 10 milliequivalents per day. Roughly, that's almost roughly around 38% falls into less than 6 category, and almost 30% fall into 6 to 10, and 33% fall into more than 10. That is a quite fairly an equal distribution of all the populations in all three study groups. And what is this 24-hour sodium correction and this 6 to 10 correction group is taken as a reference group because this was the correction rate that has been recommended by the guidelines which we had seen. And what is this 24-hour sodium correction rate? Say, for example, this is an hypothetical example just to make an understanding. So here we have a patient whose sodium level is around 110 at the time of admission, and patient is getting admitted around 2 o'clock. So you need to have a next 24-hour sodium at roughly around 2 o'clock the next day. But if you don't have any value, the current study authors took a sodium value and a time that is almost close to 24 hours. Say, for example, in this, here it's around 120 at 8 o'clock. So they take these values and put in this equation, and that's how they come with the estimated 24 hours. If they don't have a 24-hour correction rate, they'll come up with an estimated 24-hour correction rate by using this formula. And in this example, the 24-hour correction rate is roughly around 13. So by using these formulas, they divided patients into 3 categories, and they looked for 3 outcomes. The length of hospital stay, between the correlation between the correction rate and length of hospital stay, and development of central pontine myelinolysis within 90 days, and the correlation between correction rate and in hospital and 30-day mortality. These were the 3 outcomes that has been looked in this study. Coming to the patient characteristics, the total number of patients is around 3,274, and the mean age of the patient is 66, and there is an almost equal distribution of male and females, and predominantly a white race population. The average GFR is around 73. None of the patients had any renal impairment, and the mean serum sodium among the study group is 116. So this was a data from their supplementary. This is a data which summarizes the epidemiology, demographic characteristics of the previous studies, which states that hyponatremia affects both males and females equally. This is how have been reported in the current study. There is an equal distribution of male and female, and the prevalence of severe hyponatremia increases with age, and the median age is around 65 years, and almost our study also, the median age is around 66 years. There is no racial or ethnic distribution predisposition for development of hyponatremia, but 75% of US population is white, and this study is almost 80% is white. So this overall study population represents the patient population in the US population. So the basic demographic characteristics of this study is quite robust, and it's similar to the previous studies. They did a subgroup analysis among patients with different comorbidities. These were the comorbid conditions that were present in the study population. They took mainly patients with subgroup analysis was done mainly in patients with cancer, congestive heart failure, and cirrhosis who presents with hyponatremia, and these populations were selected on the basis of their higher mortality, and they have a very lower predisposition for achieving the correction rate greater than 10. These were the comorbid conditions that has been distributed among the study population. Here we can see cirrhosis constitutes about 14% of population in less than 6 group, and and more than 10 group, around 5% of population, and congestive heart failure roughly 38% in less than 6 group, and roughly 25% constitutes in more than 10 group, and malignancy is around 44 in less than 6 and 29 in more than 10. What we can see from this table is that patients with severe comorbidities, where they did a subgroup analysis in this population, majority of population falls in less than 6 group. Here it is 14 and 5, and here it is 38 and 25, and 44 and 29. And even patients with metastatic cancer were quite higher in this group. So patients with very poor prognosis falls into less correction group. Coming to the treatment that has been offered for the correction of hyponatremia, only 12% of population received hypertonic saline for management for hyponatremia. The rest of the treatment that has been done was not properly mentioned in this study. Coming to the statistical methods used, before getting into the statistical methods used, I would like to brief a very brief idea about the statistical methods used. They had used two statistical methods: the propensity score weight analysis and multivariate analysis. What is a propensity score weight analysis? The major disadvantage of any observational study is that there will not be an equal distribution of patient population. Say, for example, unlike a randomized control trial, in observational studies like this, there will not be an equal distribution of patient population. Say, for example, in this group has predominance of oranges and less of apples. And in this group, there is more of apples and less of oranges. And it will be very difficult to compare an apple with an orange. So comparison should be between an apple with an apple or an oranges with an orange. So this, when groups are indifferent for comparison, they'll use a statistical model using various parameters, and they'll calculate a score, and they'll compare the patients who has a similar score. Say, for example, here a patient with the propensity score of 0.2 and is compared with the 0.3, and here a 0.4 patient is compared to 0.4, and 0.7 is compared to 0.8. So by this statistical method, though the population distribution is different among the study groups, so by using the statistical method, it will be easier to eliminate the confounding factors. So propensity score is used to create a balance between treatment or exposure and comparison conditions, and thus this mimics an RCT. Another statistical method that has been used in this study is that the multivariate logistic regression analysis. As the name implies, it's a multivariate. They use multiple variables. Logistic regression is that by using the statistical methods, you can tell whether yes or no. To find out that this statistical method is used, whether the variables have been associated with a particular outcome. To look into that study, to look into that outcome, this multivariate logistic regression is used. Say, for example, these are the variables like age, gender, smoking habits. Whether it is associated with a particular outcome, they'll apply these variables in this statistical formula, and they'll come up with two equations, two values. The value that is either 0 or 1. If it is 1, these variables were associated with the expected outcome, and if it is 0, these variables were not associated with this outcome. So the statistical methods that have been used in this study is the propensity score weight analysis. They gave a scoring point to patients with different groups and compared with each other. And multivariable adjusted logistic regression model. They used multiple variables. In two models, they had constructed this one, model 1 and model 2. In model 1, they used age, race, sex, admission sodium, and looked for the correction rate and the length of stay. They also constructed another model by using the same variables of model 1 plus Carlson comorbidity index. I'll be coming to that, what is Carlson comorbidity index. And they also did a sensitivity analysis, because most guidelines recommend to correct sodium less than 8 and more than 8. They also did a sensitive analysis. These were the statistical methods that have been used in the study. Carlson comorbidity index, almost some 10 to 15 parameters that is there in this. Higher the score, higher the mortality. This score they'll take, and they'll construct the statistical model to find for correlation. Coming to the results, what has been observed in this study is that when the study population, those study populations in the year 1993 had a very high 24-hour sodium correction rate, touching almost 13. And over a period of years, up to 2018, the 24-hour sodium correction rate has been gradually falling, has been gradually decreasing because of the current guidelines and recommendations. Coming to the outcomes that have been studied in this study, central pontine myelinolysis. Out of 3,267 patients, only 7 patients had developed central pontine myelinolysis, which constitutes about 0.2% of patients. These 7 patients, only 1 patient in less than 6 group developed CPM, and in 6 to 10 group, which is the guidelines recommended range, around 4 patients have developed. And if we go beyond the guideline recommended range, more than 10, in their study they observed that around 2 patients had developed CPM. In these 7 patients, 6 patients who developed central pontine myelinolysis had a risk factor for CPM, like they were an alcohol use disorder or a malnutrition, or they'll be having an hypokalemia or hypophosphatemia. So very low percentage of population than the physician's anxiety. Only 0.2% developed in CPM, and majority have developed in the guideline recommended range, and even correcting more than 10, only 2 patients had developed this CPM. And what they used for finding this CPM is that they took the discharge summary of the patients, and it's a retrospective study. So they were searching for the ICD codes for osmotic demyelination syndrome or central pontine myelinolysis, and in those patients whose MRI has been done, among the 3,000 patients whose MRI has been done, they used search terms like osmotic demyelination or central pontine myelinolysis, whose MRI has been done in the first 90 days. And this is how they have picked up these 7 patients who developed a CPM. The in-hospital, the first outcome we had seen, the central pontine myelinolysis. The second outcome that has been looked in this study is the in-hospital mortality rate. We can see from this table, the in-hospital mortality rate is around, from 1,200 patients, 159 had died in less than 6 group, roughly around 13%. And in more than 10, we can see that only 56 patients had died, which constitutes about 5%. And the 30-day mortality, around 255 patients had died. That's around 21%. And and more than 10 group, the 30-day mortality is very less, only 8%. So we can see from this table that the in-hospital and 30-day mortality is quite high in less than 6 group, 13 and 21 versus 5 and 8. Coming to the statistical methods, which we had described, you can see here, they had calculated the odds ratios using the models, multivariable model 1 and multivariable model 2, and propensity weight score analysis. An odds ratio is a one which is incident among exposed and incidence among non-exposed. Ratio more than 1 means that the expected outcome is not statistically significant, there is no correlation. And less than 1 means it is associated. The expected outcome and the variable we are testing is associated. Here we can see in all these three models, less than 6 group had a odds ratio of 1.7 and 1.7 and 1.5, and the odds ratio in this group is 0.6 and 0.7. So among all the three statistical models, the sodium correction rate more than 10 had a very low in-hospital mortality rate. Coming to the 30-day mortality rate, they also calculated the odds ratio for the 30-day mortality rate. Here we can clearly see that the odds ratio for patients whose sodium correction is more than 10 is 0.6 in all the three statistical methods, and it's roughly around 2.2 in multivariable model 1 for patients with sodium correction less than 6, and around 2 in multivariable model 2 and 1.9. So even the 30-day mortality using the strong statistical methods were quite low in patients with sodium correction rate more than 10. Coming to the subgroup analysis, which we had described previously, they did a subgroup analysis of patients with cirrhosis, cancer, and heart failure. And all these patients were chosen because of very high associated mortality and difficulty in correcting their sodium. This is a forest plot. Here we can see the central line around 1, central line in 1. And if the plot lies towards the right side, it's associated with a poor outcome. And if the plot lies to the left side, it is associated with a good outcome. And here we can see the 30-day, there is no correlation between in-hospital mortality and in cirrhosis patients whose sodium has been corrected less than 6. The in-hospital mortality is not statistically, there is no difference, but 30-day mortality is very low, is very high. And among patients with cancer, in the in-hospital and 30-day mortality is high in patients with less than 6 correction group. And heart failure mortality is also high in patients with less than 6 group. Here we can see the same forest plot for more than 10 group. The plot is on the left side. So the in-hospital and 30-day mortality is quite low among all the three subgroup analysis.
Dr. Praveen?
Sir?
Yeah, about the 3 to 5 minutes. So can you just summarize with the strengths and the drawbacks?
It's done, sir. Almost done,
Yeah.
sir.
Yeah.
Yes, sir.
Oh.
So, the total length of hospital stay is 10 in less than 6 group, and 8 in the length of hospital stay is 8 in this group. So the overall stay is 2.2 days lesser in the more than 10 group. This was a visual abstract of the current study. It's a retrospective study between 1993 and 2018, where they showed that in-hospital mortality in less than 6 group is 13% and 5%, and 21 and 8 between the two groups. And length of stay is also very low in these two groups. And CPM had developed only in 7 patients. The incidence is very low, around 0.2%. Coming to the discussion, the current study suggests that in patients with severe hyponatremia, a sodium correction rate of less than 6 in initial 24 hours of hospitalization is associated with increased in-hospital and 30-day mortality and a longer length of stay compared with patients greater than 10. Similar to prior studies, they noted that the correction rate is frequently exceeded the guideline recommendation, and the incidence of CPM is infrequent. The strengths of this study is that they took a very large cohort, around 25 years of experience, and their baseline demographic characteristics is almost similar to the previous studies. And the result of this study is similar to a recent study that was published in 2023 from Macmillan et al., where they also did a retrospective study from 2010 to 2020, and they took less than 130 patient hyponatremia with a sodium less than 130, and primary outcome is the patients who developed ODS. And in their study, only 12 patients developed hyponatremia, which constitutes about 0.05%, and ODS, 7 patients who were overcorrected, did not develop this thing, CPS. Coming to the limitations of this study, we can clearly see that patients with very high mortality were skewed to a less than 6 group, like cirrhosis patients, congestive heart failure patients, and malignancy patients. Whether you correct the sodium or not, anyhow they'll die because of their underlying conditions. So the association between the correction rate and the mortality is quite questionable. And even the 24-hour sodium correction rate that has been distributed among the population, less than 6 is it's only 3, and it's very less than even the target range, the guideline recommended range, and more than 6, it's around 16. And these two variables, I am considering this as a confounding factor for association between correction rate and high mortality. Even the exact cause and the chronicity of hyponatremia is not mentioned in this study, and the diagnosis of CPM requires a neurological examination. The methodology used cannot accurately identify CPM. So the conclusion of this study is that limiting the sodium correction rate was associated with high mortality and a longer length of stay. Whether the sodium correction rate influences the neurological complications need further evaluation. I would like to date a small trivia where the Germans, we are in the month of October, where Germans were using a strategy called Blitzkrieg, where they continuously attack the enemy day and night. In this German, Hitler had made compulsory for all the soldiers to use methamphetamine to stay awake and to be as a stimulant. And subsequently, over a large number of soldiers had developed an hyponatremia, and that's how they found out the link between hyponatremia and methamphetamine. The take-home message is that the study looked not only the neurological outcomes of sodium correction rate, but also it looked into the influence on mortality and length of stay. The observed central point myelinolysis frequency is overall very low, even in patients with high sodium correction rate. Though the study used a very strong statistical methods to eliminate the confounding factors, whether patients in low sodium correction group had a very high mortality secondary to their underlying comorbidities or because of slow sodium correction cannot be ruled out.
Thank you, Dr. Praveen. I invite Dr. Gopalakrishnan sir and Dr. Ravindra Prabhu sir to initiate the discussion and get some points from our authors also.
I think Dr. Gopalakrishnan sir. Good evening, and thank you for allowing us to take part in this fine discussion. I must commend Dr. Praveen from the Manipal Hospital, Bangalore, for thoroughly discussing and bringing out the nuances of this study. With permission from Dr. Gopalakrishnan, I would just give a gist. What he has discussed is that it's a large cohort, and the system allows for almost getting the data right from 1993 with such a kind of granularity, which would be difficult in any other system. But however, it's a retrospective, as he has brought it out, it is a retrospective analysis. And whether the slower correction is actually selecting people with higher comorbidities, which are anyway going to have a higher mortality. So this is what he's brought out, and whether there is real evidence to turn the guidelines over. This is based on this retrospective analysis. This is what we should be discussing. I request Dr. Gopal Krishnan to give his comments.
Yeah, I think we can ask the authors, Dr. Sagar and Dr. Harish, both are there, to give their comments about it. Because see, nowadays, more and more, one thing I could see in the study that the use of 3% saline was quite low, which is more and more recommended nowadays, even for any type of hyponatremia. And obviously the Ravindra has pointed out that the patient with low correction had more comorbidity, and that is responsible for higher mortality in that group rather than the actual low this thing. So what are your comments, Dr. Sagar, Dr. Harish, and how should we?
One more point I would like to bring out. There is a, as he told, there is an increased representation of congestive cardiac failure and cirrhosis and the metastatic cancer in the low correcting group. Now, these are situations where you would try to restrict the fluid and maybe give the diuretics. And the decision to give the saline would be later on. And that may be one of the reasons why this group has had a slow correction and lesser use of the hypertonic saline is there in that group. Again, there is, even though they have done a subgroup analysis, whether there is a change in the severity of the condition itself, more severe cirrhosis, less severe, and as we can easily make out, the comorbidity index is also more in this group. So whether we are selecting a sicker population for slower correction and the sicker population has more mortality, and it's not the correction which is causing the mortality. So this is the thing, even though the propensity analysis is done, I would say that it is not as good as doing a control trial. Of course, it's difficult to do a control trial in this situation. But these are the things which we would like to get out from the authors.
And my reflections would be, first of all, my appreciation to the presenter, Dr. Praveen, and very nicely done. I concur with Professor Ravindra Prabhu as well. There are very few papers that they really kindle a lot of interest in the nephrology academia as well as critical care, intensive care academia. One such paper is the Harish Sitapati and others paper. Congratulations to the group of authors, and I'm happy that we do have a couple of authors with us. Why I say that is that, people of my age, we are all kind of attuned to the very stringent idea that, your correction has to be very cautious and the correction has to be gradual and slow. I'm just recalling the famous nephrology forum of 1990, Kidney International, titled as Treating Hyponatremia, Damned If We Do and Damned If We Don't. So we grew up with that and the idea. So this paper is really kind of excited people of my age kind of. And subsequent to this paper, also there is one more report, Journal of Critical Care, almost vouching similar results and so on. But at the same time, I concur with Professor Ravindra Prabhu. There are so many other issues there, even though propensity scoring has been done and whether all the confounders have been absolutely taken care of, and it is impossible in a retrospective study and so on. My doubts are that, are we sure and certain about the indications for asking for an imaging like MRI? 2 decades ago, what were the indications? So whether some or more osmotic demyelination could have been missed. That is number one. Number two, as we all know, this myelinolysis has got a wide range of severity. There are many patients who would have very subtle neurological signs, and the image before the imaging is asked for, it may just resolve. And also, the imaging MRI findings take some weeks it does not happen concurrently with the clinical picture, the neurological deficit. That's what I understood. That there can be some delay. So before, if the neurological phenomena subside, MRI could not have been done as well. So there are a lot of caveats in this, and I am sure you might have, at least some of you might have come across another write-up in JASN on behalf of a pro-natrius group, and they are cautioning us not to jump into quick conclusion. And so they say if doing so would be akin to discarding your umbrella because you remain dry in a rainstorm and so on. I think this kind of a controversy and heated debates and discussions will continue in the near future. I would love to hear from the original authors themselves.
Thank you so much. I'll go first. This is Harish, Dr. Bansal, Dr. Prabhu, Dr. Gopalakrishnan. Thank you for your comments. I think with respect to the residual confounding part of the comments, we totally agree. The association does stand when a propensity weighted analysis is done and within subgroups. But as Dr. Prabhu mentioned, it may be that there are certain patients, even within subgroups, who are sicker than the others. So we do not dispute that, meaning I think this particular association has been consistent throughout many other studies. And I don't know if residual confounding fully explains that. And we've tried looking at it in more granularity, even looking at comorbidity scores within a particular subgroup and seeing if the association stands, and it does. But I do think more work needs to be done to kind of figure out if it's just residual confounding versus there's something else going on. But I think it would be very hard to make the statement that, you know, it is the lack of correction alone that is causing the increased mortality. I think that would not be a fair statement to make at this time, but I do think we need more studies to sort of explore that association. But coming to the second and probably the more interesting point, which is the whole aspect about CPM, and Dr. Gopalakrishnan nicely mentioned sort of a historical nuance and some of the discussion that happened in the 90s. But I want to go back sort of even further back. The very first report of CPM came back in like 1959. And at that time, if you look at the title of the paper was a hitherto undescribed disease occurring in alcoholic and malnourished patients. And throughout the next sort of 20 years, you can see that there were multiple reports, some of them consolidating multiple case reports, many registries, and everything sort of denoted a high proportion of patients with alcoholism and malnutrition. Those were the two primary sort of risk factors that were mentioned. And then people are, of course, looking for what precipitated this, or, you know, what other risk factors there might be. And then came the original Stearns paper and some other studies which noted hyponatremia and hyponatremia correction as possible risk factors for CPM. But I'd like to note that, like in many of those initial case series, you know, the sort of mention of the incidence of ODS is pretty high. It was 15 to 25%. Even though there was not many patients in which imaging was done or autopsy series were performed, they did mention that, hey, it occurred in a large proportion of patients. So I think, you know, compared to the 1960 to 1980, by the time we got to the 90s, I think the term CPM and ODS was slowly separated. And as Dr. Gopalakrishnan was mentioning, now the dogma is that, you know, the clinical diagnosis of ODS is just clinical, meaning it doesn't even need a radiological imaging to sort of like differentiate from it. But we forgot one main important thing here, which is that in the last 20 years, all the emphasis has been on sodium correction, but we just didn't emphasize sort of the risk factors that came with the individual patient, which I think still stands as malnutrition, alcoholism, other electrolyte abnormalities like hypokalemia, hypophosphatemia. Because even with normal sodium, and you guys have seen these case reports over the last 10, 15 years, whether it's not patients with normal sodium or patients with, you know, low correction rates, these people still get signs of CPM even on imaging. And I think clinical ODS, I think, is sort of a wishy-washy sort of condition. I think it's very hard to sort of pinpoint and have criteria as to what constitutes a diagnosis of clinical ODS. I say that primarily because you're looking at a population with a very high risk or high burden of neurological disease, right? Like if you're looking at severe patients with severe alcoholism or severe malnutrition, they already have baseline neurological findings, and to actually figure out if a sodium correction that happened a couple of months ago led to worsening of neurological issues now, again, I don't know how we can clearly make that association. I think that's the tough part here. So overall, I think, my main sort of comment would be that, yes, I do think, sodium correction is a risk factor, but I do not want it to come at the cost of like not recognizing the other more important risk factors such as alcoholism, malnutrition, etc. Especially because once these guidelines sort of got instituted, we treat every hyponatremia patient the same. And I'm sure it's kind of similar in India, where any patient who comes to the hospital with chronic hyponatremia, we implement these guidelines. We don't necessarily look at whether that patient has a high burden of alcoholism, malnutrition, other neurological disease, other risk factors. We have the same guidelines. And I think that's where the discussion should be, as to have more nuance in the guidelines. Even though they stated, the practice has been that, we traditionally use the same limits for everyone, and that's where I think it needs more study.
Yeah.
Dr. Harish,
If I may just add quickly to what Harish just said. First of all, thanks again for having us, and fantastic presentation by Dr. Praveen. I think it's important to probably take a step back and just highlight maybe the limitations, of course, of the data, which for most part have been already articulated. But I think where we are now in 2023 compared to, let's say, back in 1990s, is really at a point where we can leverage these large databases and still find granular information, as Harish has done here, painstakingly looking at the MRI reports, looking at the patient level data among those patients who developed central pontine myelinolysis features, for example. The issue about, of course, confounding is going to be bugging us in this field, or for any retrospective study, and it's not going to go away. But I think at least we feel comfortable that within the subgroups like cirrhosis patients or with heart failure patients, the overall signal remains consistent. Now, of course, that doesn't imply causality, but allows us to think about these patients in future studies, like prospective studies, where we can really hone in on these specific populations and understand what are the determinants of different rates of correction. And then among those patients who do proceed with different rates of correction, can we do protocolized neurological assessments to understand just the subtle but also overt neurological manifestations, like maybe subtle confusion or subtle dysarthria. Now, some of them could be just the result of hyponatremia itself, and that will be difficult to sort out in a retrospective study such as this. But just coincidentally, there was a paper in the neurology literature looking at very corresponding database, but they focused more on the neurological outcome side. And they observed, they reported many more cases of CPM, but they were not focused on specifically hyponatremic patients. But if you look at the kind of the overall CPM or ODS cases in the same database over the similar duration of study, you actually find that most cases of ODS or CPM did not occur in patients with severe hyponatremia, and in fact were not linked with rapid rate of correction. So that just opens up the possibility of this whole link between ODS and rapid correction of hyponatremia. Is this just true, but not necessarily related? The MRI finding point was a good one. And in fact, in this study, we did look at the MRIs up to 90 days. So patients who had an opportunity to develop something like CPM or at least the radiological findings way beyond the rate of corrections.
I have one more question, if I may, to the authors. Whether you got any upper limit beyond which it was unsafe. Like we say, about 10 is having less mortality. But was there any upper limit beyond which, you could expect more ODS or more mortality? Like the guidelines say you should not do more than 16. Previously, they used to say more than 20. Definitely the ODS is more. So is there some signal like that?
I think that would be a hard question to answer just because we had so few cases of CPM, and out of our 7, cases, like 5 of them corrected less than 10. But I think that in a very high risk patient, like if you have a patient with severe malnutrition, long history of alcohol use, very low sodium, and they start out, I actually don't think we do know the exact safe level at which they can be corrected. The slower the better, probably. But even if you correct slowly or you do not correct at all, you can still have CPM in these patients. So that's the hard part. But in most other patients without these risk factors, I do think correction of 10, 12 would possibly be okay. But again, I don't think we have enough clarity of data to show us that a particular cutoff is the one that would be the safest.
Thank you all. I guess we are having some questions in the chat box. We'll at least take a couple of them. One would be, at what rate of sodium correction would you start sodium lowering strategies? This would probably be important considering both the studies had shown that the incidence of CPM was quite negligible. So is there any particular cutoff which you use or which all of you advise?
I think that's probably one of the best questions to prospectively study. Right now, I do think we spend an inordinate amount of time and effort in trying to reduce the sodium when we go over these limits, regardless of, as I said, the underlying risk factors. I do not think we need to, now I'm speaking more opinion and anecdotes rather than going by data. But in my practice, I do not think, I would relower if somebody crosses 12 in a very low risk patient, meaning if the patient was not a cirrhotic or, did not have congestive heart failure or malnutrition, would I lower it if the limit was, if the sodium went up by 13 or 14 in the first 24 hours? Probably not. But in a very high risk patients, I may. But again, I don't think there is enough data for me to know that by doing that, I'm necessarily lowering the risk. I'm just protecting myself, but I do not know if that does anything,
And the question was, if at all we are going to measure the serum sodium, will it make a difference if we measure it at 6 hours and then at 24 hours to see whether the rate of correction, the change in the rate within a day matters or not? Because right now we are just measuring at 24 hours. So if someone has an initial increase and then plateaus, or initial plateau and peaks, so would that affect the outcome?
With regards to ODS, I can say not, because we did look at the highest rate of correction in any 24 hours, within any sort of time period. And I think we put that in the table for our cases of ODS, and I don't think it made a big difference. With regards to mortality, that's a harder question to answer, especially because I do not think there's a clear sort of cause and effect in terms of sodium correction mortality yet. So whether changing correction rates would impact mortality, I do not think we know yet. And I think that's what probably needs to be studied. But in practice, my sense has been, and my frustration also has been, that the use of hypertonic saline is very low. In our study, it was 12% in the first 24 hours. And I think that's extremely low in this population. And there's a lot of hesitancy in using hypertonic saline because people feel that you will overcorrect if you use hypertonic saline. But that's where I would say that in high-risk patients, you should use hypertonic saline to start with. You should sort of monitor sodium closely. And you shouldn't have this much hesitancy in using a treatment when the risk of the treatment, which is overcorrection, and 1/3 of patients overcorrect, nothing happens. When the actual sort of like risk of ODS is so low, I do not think we should be this hesitant in treatment, especially throughout the hospital stay. as you can see, it increases the length of hospital stay, which again can lead to bad outcomes.
And I guess one clinical question was, if the patient presents with seizure, considering the risk of an hyponatremic encephalopathy, would you still have the same correction thresholds? In other words,
I think things go out the window. I think if somebody is symptomatic, acutely symptomatic with hyponatremia, I think it's more important to raise the sodium immediately by 4 to 6 or whatever is recommended. In an acutely symptomatic hyponatremia patient, I think correction rates come second in such patients. Dr. Nigwekar, do you do it any differently?
No, I completely agree with you, Harish. In terms of, I think of course, the volume depletion, if that is the cause of severe hyponatremia, as is highlighted in that question, of course, the first strategy will be to correct volume depletion, and sodium correction, whatever happens. And of course, if it does take hypertonic saline to correct that volume deficit, then that will be the ideal way to do it. But I just want to also kind of just highlight that in a patient who has this co-occurrence of volume depletion and hyponatremia, the volume trumps the hyponatremia.
We are nearly completing to 9 o'clock, so would like to commend the authors for such a wonderful, robust data collection. And one final word from all the panelists and the authors regarding whether we can let the guard down with regard to sodium correction, and what would be your preferable correction rate in EDDI? Just a couple of sentences from all the panelists.
So first of all, I commend the presenter for bringing out all the nuances, and the author, Dr. Harish Sitapati and Dr. Sagar, for this excellent article, having painstakingly taken data for last almost 30 years, and getting that kind of granular data is something really challenging and most difficult, and really congratulate you on that. The message we are getting from this paper is that the ODS or the pontine myelinolysis is a rare phenomenon, and it can occur whether you correct slowly or the rate of correction may not influence that to that extent. But certainly, if you correct slowly, the mortality seems to be higher. Whether that mortality is higher because of the comorbid conditions or due to the correction is not, probably we cannot answer with this kind of retrospective. But it gives us a guidance that maybe you could go a little faster. I'm not saying that you should go very fast. You could go a little bit faster. You need not feel that challenge to go so slowly. So that's probably the message we can get from this.
My reflection will be like, I will still be exercising caution in patients with severe hyponatremia and with all the risk factors, high risk for myelinolysis, like severe malnutrition, alcoholism, and associated hypokalemia, and so on. But in a given patient, if these risk factors are not there, I'm slightly getting emboldened to kind of accelerate the rate of correction. But still, I will be awaiting further data to really get bolder in this direction. More such data will be encouraged, and we are eagerly awaiting for that. And it's quite interesting and very contentious issue, and we are really getting it.
One of the interesting observation in the chat box was the data was collected from 1993, but the first case of central pontine myelinosis was noted only in 2005. Any comment from the authors?
Yeah, I did reply to that comment. We actually looked at that in pretty much every single way you could possibly can. We actually pulled every single MRI for every patient ever admitted to the hospital who had any of the code words for pontine myelinolysis or ODS or all of that. And we cross-checked it with our database, and we didn't find an additional case. Yeah, it's one of two things. I think either MRIs were probably not performed as often as we do imaging since the 2000s, which I think is more often. And so perhaps there were cases that, clinicians felt that MRIs didn't need to be done. So perhaps there were milder cases of ODS that we caught post 2000 that were just on imaging. As you can see, some of our cases of ODS were really mild clinically, meaning most of them recovered really well and didn't have many symptoms. The other explanation is there were just no cases at that time, and it's just, rare things that happen even with two big hospitals. So it's one of those two explanations, I think. But we did cross-check it with every single MRI with those findings during the time period, and we didn't find an additional case.
Yeah, interestingly, obviously, the goal of the paper was not to suggest to anybody that correction rates of sodium are not relevant to clinical practice. This is obviously a paper that is more of a hypothesis generating and requiring kind of a rigorous prospective study for evaluation, not necessarily a trial, but at least a prospective examination. But just kind of interestingly, around the same study period, there were many more cases of CPM that were identified in the same data set, but very few of them had severe hyponatremia, and almost none of them had rapid correction of sodium. So the issue about, these the initial, 12, 13 years of the study did not have ODS. Yes, we did not see those in our database, but it was not like other settings were not identifying CPM or ODS in the same corresponding period. It's just that when you want to have the both criteria satisfied, CPM and rapid correction of sodium, there was nobody who met both of those criteria.
Yeah, just backing up on that, I think, we did have many cases of CPM in that time period, but many of them had either completely normal sodium or slightly low sodium.
Arun, you want to have the closing comments?
So I would like to thank Dr. Praveen, our panelists, Gopalakrishnan sir and Ravindra Prabhu sir, Dr. Harish Sitapati and Dr. Sagar Nigvegar for taking out your time for such a wonderful discussion. I guess we are having many questions in chat box. Probably we'll try to do one thing, that we'll try to reply to the rest of the questions in a form of a mail because of time constraints. And as always, I would like to commend the authors for such robust data collections. I guess I don't know if we'll be able to ever collect such big data and present in such a nice manner. And I would like to thank all the attendees for having taken part in this discussion. And we hope to meet you next month on the third Wednesday as always. Thank you all. Thank you.
Thank you.